Welcome, medical students, to today's lecture on the topic of optic neuropathy. In this lecture, we will explore the various aspects of optic neuropathy, including its pathophysiology, differentiating types, associated systemic diseases, neuroimaging techniques for evaluation, genetic and hereditary factors, and its association with multiple sclerosis, autoimmune conditions, pediatric cases, metabolic disturbances, optic neuritis, medication and toxin-induced optic neuropathy, compressive causes, and those associated with central nervous system infections. By the end of this lecture, you will have a comprehensive understanding of optic neuropathy and be equipped with the necessary knowledge to diagnose and manage this condition effectively. So, let us begin our exploration into the fascinating world of optic neuropathy. Ischemic optic neuropathy, a common cause of sudden vision loss, occurs due to inadequate blood supply to the optic nerve. This insufficiency can arise from various factors such as arteriosclerosis, vasculitis, or embolic occlusion. When the blood flow to the optic nerve is compromised, ischemia manifests, leading to hypoxia, energy depletion, and subsequent neuronal damage. This damage primarily affects the retinal ganglion cells and their axons, resulting in a characteristic pattern of visual field defects and optic disc changes. The exact pathophysiological mechanisms underlying ischemic optic neuropathy are still under investigation, but it is believed that a combination of primary vascular events and secondary inflammatory processes contributes to the overall damage. Optic neuropathy can often be a manifestation of systemic diseases. Several conditions, such as diabetes mellitus, hypertension, systemic lupus erythematosus, sarcoidosis, and giant cell arteritis, have been associated with optic neuropathy. These diseases can directly affect the optic nerve through various mechanisms, including inflammation, immune-mediated damage, or occlusive vascular events. Additionally, the systemic manifestations of these diseases may indirectly impact the optic nerve, leading to secondary optic neuropathy. It is crucial to recognize the underlying systemic disease in patients presenting with optic neuropathy, as early identification and management of the primary condition are essential for successful treatment of optic nerve involvement. Neuroimaging plays a pivotal role in the evaluation of optic neuropathy. Several imaging modalities, including magnetic resonance imaging, MRI, computed tomography, CT, and optical coherence tomography, OCT, are valuable tools for assessing the anatomy and function of the optic nerve. MRI provides detailed structural images of the optic nerve and surrounding structures, aiding in the identification of compressive lesions or inflammatory changes. CT scans are particularly useful in detecting bony abnormalities that may impinge on the optic nerve. Furthermore, OCT enables non-invasive assessment of retinal nerve fiber layer thickness and can help quantify optic nerve damage in various optic neuropathies. Integrating these neuroimaging techniques with clinical findings assists in accurate diagnosis and treatment planning for patients with optic neuropathy. Genetic and hereditary factors contribute significantly to the etiology of optic neuropathy. Various inherited mitochondrial disorders, such as Leber hereditary optic neuropathy, LHON, and dominant optic atrophy, DOA, result in optic nerve dysfunction. LHON is characterized by bilateral, painless vision loss predominantly affecting young males, and is associated with specific mitochondrial DNA mutations. DOA, on the other hand, presents with slowly progressive bilateral vision loss, often with a positive family history. Genetic testing plays a crucial role in identifying these hereditary optic neuropathies, enabling appropriate genetic counseling and potential future therapeutic interventions targeting underlying genetic abnormalities. Multiple sclerosis, MS, is a chronic autoimmune disease characterized by demyelination and inflammation within the central nervous system. Optic neuropathy can be an early manifestation of MS, occurring in approximately 20% of patients. The optic nerve involvement in MS, known as optic neuritis, classically presents with rapid onset monocular visual loss, pain with eye movement, and a relative afferent pupillary defect. The pathogenesis of optic neuritis in MS is thought to involve an autoimmune attack on myelin proteins within the optic nerve. Recognizing optic neuritis as an initial presentation of MS is crucial for early diagnosis and appropriate management of the disease. In addition to optic neuritis associated with multiple sclerosis, autoimmune optic neuropathy encompasses a broader spectrum of inflammatory optic nerve disorders. Conditions like neuromyelitis optica, NMO, and autoimmune optic neuropathy, AON, share overlapping clinical features with MS-related optic neuritis, including acute vision loss, pain, and characteristic visual field defects. Differentiating between these conditions is essential, as treatment strategies and long-term prognosis may differ significantly. Immunosuppressive therapies targeting the underlying autoimmune process play a critical role in managing autoimmune optic neuropathy and preventing further systemic complications. Optic neuropathy can also affect the pediatric population, albeit with distinct clinical features and etiologies. Pediatric optic neuropathy may arise due to genetic factors, congenital anomalies, inflammatory conditions, or acquired systemic diseases. Conditions such as optic nerve hypoplasia, Leber hereditary optic neuropathy, mitochondrial disorders, and vitamin deficiencies can lead to visual impairment in children. Additionally, inflammatory optic neuropathies, akin to those seen in adults, such as optic neuritis, can also occur in the pediatric population. Prompt recognition, thorough evaluation, and appropriate management are vital to preserving visual function and optimizing the quality of life for these young patients. Metabolic disturbances can impair optic nerve function, resulting in metabolic optic neuropathy. Nutrient deficiencies, such as vitamin B12 or folic acid deficiency, can lead to optic nerve damage and subsequent vision loss. Additionally, disorders like Leber hereditary optic neuropathy, LHON, and certain mitochondrial disorders can impair oxidative phosphorylation, leading to optic nerve degeneration. Timely identification and correction of metabolic abnormalities are crucial to prevent irreversible optic nerve damage and optimize visual outcomes in these cases. Optic neuritis refers to the inflammation of the optic nerve and is a common cause of acute visual loss. This condition can occur in isolation or may be associated with systemic diseases like multiple sclerosis, neuromyelitis optica, or other autoimmune disorders. The classic presentation of optic neuritis includes acute unilateral vision loss, pain with eye movement, color desaturation, and a relative afferent pupillary defect. MRI imaging of the brain and orbits, analysis of cerebrospinal fluid, and visual evoked potentials aid in confirming the diagnosis and assessing the likelihood of systemic involvement. The use of systemic corticosteroids and immunomodulatory therapies has revolutionized the management of optic neuritis, leading to improved outcomes and reduced risk of recurrence. Certain medications and toxins have the potential to induce optic neuropathy. Ethambutol, an anti-tubercular agent, is a well-known cause of toxic optic neuropathy, leading to bilateral vision loss and central scotomas. Other medications, such as chloramphenicol, amiodarone, and vigabatrin, have also been associated with optic nerve-related side effects. In addition to medications, exposure to various environmental toxins, including methanol and tobacco smoke, can result in optic neuropathy. Prompt recognition and discontinuation of the offending agent are crucial in managing medication and toxin-induced optic neuropathy. Compression of the optic nerve due to space-occupying lesions can result in compressive optic neuropathy. Tumors, aneurysms, vascular malformations, or inflammatory processes can cause compression on the optic nerve, leading to visual disturbances. Symptoms may vary depending on the location and extent of the compression, but common manifestations include progressive visual field defects, decreased visual acuity, and color vision abnormalities. Prompt identification and timely intervention, such as surgical decompression or tumor removal, are essential to prevent permanent visual impairment. Central nervous system infections can involve the optic nerve, leading to optic neuropathy. Conditions like tuberculosis, syphilis, Lyme disease, and viral infections, for example, herpes simplex, varicella zoster, can cause optic nerve inflammation, resulting in vision loss. Accurate diagnosis and targeted antimicrobial or antiviral therapy are required to manage the underlying infection and halt further optic nerve damage. Collaboration between neurologists, infectious disease specialists, and ophthalmologists is crucial for the optimal management of optic neuropathy in the context of central nervous system infections. In conclusion, optic neuropathy encompasses a diverse range of conditions with distinct etiologies, clinical presentations, and management strategies. Understanding the pathophysiology, recognizing associated systemic diseases, utilizing neuroimaging techniques, considering genetic and hereditary factors, and comprehending the different types of optic neuropathy are key aspects in the evaluation and management of this complex condition. By incorporating a multidisciplinary approach, involving neurologists, ophthalmologists, geneticists, and other specialists, successful diagnosis and treatment can be achieved, ultimately leading to improved visual outcomes and a better quality of life for patients with optic neuropathy. We hope this comprehensive lecture has enhanced your knowledge and appreciation for this fascinating area of neurology.